Welcome to the latest episode of the Melbourne Athletic Development Podcast. Today I'm joined by Jack. However, he meets us from Norway. Jack, what are you doing in Norway and why do you look like a tomato?
Well, it turns out Norway has sun as well, even though today looks pretty cloudy if you can see the sky outside. So I'm over in Europe at the moment doing another round at the Fascial Manipulation Institute as a part of the international school program I'm doing with Carla and Antonio Stecco. And I've got a bit of a break before I go back and do some more coursework. So I thought, why not go and check out the fjords of Norway? But I was out hiking yesterday and did a big hike through some mountains, and there's still quite a bit of snow there, even though it's summer here. And clearly the snow got, and the reflection of the sun off the snow got the best of me, and I'm nice and red today.
For our listeners, do yourself a favor and watch this video or get a little bit of a look at this video on our YouTube channel. You'll very much enjoy, I think, the appearance that Jack has turned up with today.
To be fair, I feel like this video footage is making me look a lot worse than what I actually am, but I'll just have to take it.
We'll let them judge whether you look bad or. So what we thought we would do is obviously you continue to do this coursework and it obviously keeps going up in terms of what you're learning. So we thought it would be a really good opportunity for us to evaluate, where you're at with that and, what are some of the things you're starting to pick up as you kind of progress through these courses, because it's obviously a very extensive course that you're doing. And for the uninitiated, it would seem like, okay, there's some in-depth anatomy, but what else is there to do once you've kind of worked out what those anatomical connections are? What are the next steps? So I'll leave the floor to you, but what's something that you've picked up on this latest course that you've just undertaken?
Well, what we're moving into now is getting into an interesting area because it's looking at the connections of the internal fascia, so specifically the visceral fascia and the musculoskeletal system. So I've talked about this before many times in different podcasts of when we start to integrate fascia into anatomy, we can start to see that muscles have continuity through the deep muscular fascia. And that's what forms myofascial chains that a lot of people would have heard of before. And that's really important to have an understanding because it gives you an important understanding of movement and force transmission and why we do certain movements to be able to create forces through a series of muscles and fascia to create much larger amounts of force. So a good example of that is, say, throwing or running. But I think the other thing that's really important is understanding how we can get myofascial referral pain. And that's also particularly important because a lot of things that we see clinically often fit into that non-specific type of presentation, that myofascial pain. This is some of the stuff that we talked about with John Sherbel. So, particularly when you're seeing people who don't necessarily present with structural damage, a soft tissue strain or a sprain. And a classic example of this is low back pain because the majority of low back pain is non-specific in nature. And we can also then start to explore the relationship between the internal system and then the musculoskeletal or myofascial system. This is actually something that's been explored a lot. And I think the first thing that people would often think about is we can see a lot of referral patterns from viscera into the musculoskeletal system. And there's actually been a lot of maps. Are you going to say that?
Straight away, yeah. Do you want to talk about that? Because straight away, this makes me think of something like the Eastern medicine and the connections that they traditionally spoke about between, certain organs and, musculoskeletal presentations. And as someone who's, come through more of the Western school of medicine, you always thought, okay, like they seem to be making tenuous links here, but is there these connections that we're talking about? Do they present in a similar way to what, people may have been exposed to in something like Eastern medicine?
I'm not sure if I can comment on that just because of my lack of of knowledge in Eastern medicine. But I think a good place to start, and something that is not controversial, is there's a lot of different maps that's been done in published research within the Western world of looking at referral pain from viscera. So like a good example might be pain from the lungs can refer up into that sort of first rib infraclavicular region here, or pain within the pancreas or the liver can present around the area of where the liver is, or pain within the kidneys can often present with pain in the lower back, groin, adductor region. And these are not controversial things. The thing that is controversial, or not controversial, so to speak, but at least you see a lot of variation in these maps based on different researchers' mapping of it. And that actually is an important place to start, I think, because at the moment, a lot of people think that the relationship between pain that generates from a viscera into the musculoskeletal system is due to the neuroanatomical relationship. So you remember with your viscera, it's innervated predominantly by a particular nerve root. And so if you get dysfunction of a particular organ, that sends afferent feedback that then can potentially generate pain within the somatic body, within the region that's innervated by that same nerve in the musculoskeletal system. The limitation with that, though, is, as I mentioned before, there's actually lots of different maps to demonstrate visceral referral pain within the musculoskeletal system, which doesn't really make sense, because if it is just purely a neurological relationship, you'd expect to see a consistently similar type of pain pattern from person to person. And that's actually very similar to looking at myofascial referral pain. And like I think of, say, the Travell and Simon's work, which, I mean, I'm not disregarding their work. They've done some great work of describing myofascial referral pain, but they look at it purely through the neurological relationship. Yet you see time and again that referral patterns from particular muscle or fascia vary a lot with the particular plane, and whether they go proximal distal, distal proximal, they wrap around maybe to the antagonist side. And we see similar things with the viscera. And what the Stecos have been looking at specifically is, well, how do we explore this variation in pain from viscera, and how the fact it actually varies quite a bit? And to no surprise, they're obviously looking at the fascial relationship between the organ and the musculoskeletal system. And you see that there's a very specific organization of fascia with viscera. So just to explain briefly, you've got an organ, your stomach, pancreas, liver, or whatever it is. You have its investing fascia. So the investing fascia is almost like the epimysium, or similar to the epimysium of the muscle. So it's a very thin, more elastic type of fascia that covers the organ. But then the organ is then suspended in what's called the insertional fascia, because remember, your organs are suspended within whatever cavity we're talking about. So in this example, we're talking about the abdominal cavity with, say, the liver or the stomach. So the insertional fascia holds that particular organ in place, and the insertional fascia has continuity up into the peritoneum, so the fascia of the abdominal wall. And so straight away, if you look at it from an anatomical standpoint, you can see that there is an intimate relationship between the organ to the essentially musculoskeletal wall, or the abdominal wall, through this insertional fascia. Yeah.
During this training, have you been doing cadaveric work as well? Like, did you get the opportunity to do that?
No, we have. We haven't done anything yet with the viscera yet, but I know we plan to do that, I think, early next year. But Luigi, Carla, and Antonio Stecco actually very recently published a book in English of looking at the anatomy of the internal fascia. And they've started to publish more and more work into this to explain specifically this relationship. And just to go on then, so you're thinking about the insertional fascia that essentially provides a bridge between the organ and the abdominal wall in this example, and it's much more stiffer. It's almost more like your aponeurotic fascia, like your thoracolumbar fascia. This then helps us to understand that if you start to get changes within the visceral fascia, which we see that's evident in dysfunction of an organ. So if you start to see people who continually get things like gastritis or have issues digesting certain food, indications of a dysfunction of the stomach in this example, that often starts to be characterized as changes in the mobility and stiffness of the investing fascia of that organ, which as you start to lose that mobility, that can then also create then stiffness of the insertional fascia that provides the bridge between the organ and the abdominal wall. So when you start to see these changes and you see an increase in stiffness of that insertional fascia, it can then start to pull on the abdominal wall and create some of the pain that's experienced from visceral dysfunction and explain visceral referral pain.
Does it go in both directions? Like, do people, are you guys discussing the idea that people get potentially sort of like, discomfort in, say, their stomach or something like that associated with musculoskeletal, issues and vice versa?
Yeah, absolutely. So the relationship I'm describing there is more the viscerosomatic. So dysfunction in the viscera then starting to manifest as pain in the somatic system. But yes, you definitely can see somatovisceral type problems too, at least clinically. They seem to be a lot less common. And from an evolutionary standpoint, it makes sense because if you think about prioritizing a hierarchy of importance, function of your visceral system is much more important than your somatic or musculoskeletal system. So it seems to be less common, but there does seem to be clinically a relationship that does suggest that prior musculoskeletal injuries can cause visceral problems. And that obviously becomes much more obvious when you think about the type of surgery you've had. So an example might be, like, say you've had repair for an inguinal hernia. Obviously, because of the more intimate relationship between that area and the pelvic region, you may be more likely to see issues manifest as problems with your reproductive system or problems with, say, your colon and your digestive system.
In terms of how you actually go about, one, identifying this and seeing these presentations, and also to, well, maybe start with that. How are you kind of identifying what would be considered visceral referral versus pain that is derived purely from that musculoskeletal source?
Mm. Well, I think this is where something that's really important to consider is understanding the cause of the problem. And so I think that's something that, we've talked a lot about with musculoskeletal injuries, about understanding what may be contributing to someone's presentation. And this particularly in sporting and athletic endeavors is related to things like tissue capacity, biomechanics, your hormonic profile. And those are things that I don't think you dismiss in this situation at all. But I think it's really important to consider the status and health of someone's other systems outside of their musculoskeletal system. Because I think that's a really important thing to make sure you have an understanding of, is not just what the problem is, but why you think they're developing it. And that certainly seems to become a lot more complex with a lot more of these non-specific type presentations. I think the other thing, though, to consider with that too is you'll get indications of viscerosomatic type problems based on their pain pattern. So a good example could be if someone's presenting with low back pain and they're experiencing it after eating certain types of food. That obviously gives you an indication for some type of viscerosomatic problem. Or, for instance, if they experience pain more at night, it doesn't seem to be related more to mechanical movement. So you can't necessarily reproduce their movement with certain types of movements or objective measures. So then the other thing then to consider too is it often then presents with dysfunction of other non-musculoskeletal presentations. So they get reflux. If we're talking about a gut-related issue, they get reflux. They have food intolerances. They have changes in their bowel movements frequently. They get gastritis. They get colitis. So a lot
Yeah.
of these things is often about putting together the clinical picture to think about how other indicators of their health and well-being, or changes in their health and well-being, may be an indication for some type of internal dysfunction.
Yeah, I think like I always think about this when, as you said, the first sign is that their pain pattern doesn't really follow something that would be considered mechanical. They're
Mm,
having pain at times where you don't feel that there's been an increase in the level of activity. There's no accumulation of, say, mechanical stress. And so straight away you start thinking, okay, maybe something else is driving this. And obviously it may be visceral, but it may even be things like infections and things like that. Like I
absolutely.
remember the first time I was really, chuffed with myself when I kind of picked this. I felt like someone clearly had something that wasn't related with a presentation of shingles
Mm,
where, one, the pain was kind of this rat wrapping type pain that they get around that like lumbar region and that around the side of their body. But it just didn't seem to match anything that was associated at all with mechanical stress. And
mm,
so to me, that seems to be like the big thing that if someone continues to present with pain that doesn't really seem to follow a pattern of any mechanical stress, I start to these days at least think about what else needs to be investigated. And it often means getting, other health professionals involved in that investigation.
absolutely.
In ter-
Go on, keep going, John.
yeah. No, I was going to ask you exactly that of like, if it becomes really clear now that I'm sure you're starting to get a little bit more confident with identifying, oh, okay, I think this might be some sort of visceral, issue. What's the process by which you determine whether some sort of, musculoskeletal treatment modality, such as, fascial manipulation might be useful, or no, that's actually a kidney dysfunction. They need to go and see a nephrologist. Like, what's that
Yeah.
kind of differentiating line?
Oh, well, look, I think the first and obvious thing is if someone presents with some type of non-musculoskeletal pathology, like they clearly have kidney disease, they clearly have irritable bowel syndrome, um, they have pneumonia, as an example, you have to obviously understand and appreciate that those are things that you're not going to be able to treat through non-medical management. So I think it's really important that, for any clinician, you need to be able to identify pathology outside of the musculoskeletal system and refer on when needed. I think the thing
Mm.
that becomes challenging is when you have a lot of these subclinical presentations. And to be fair, a lot of us probably have experienced ourselves where you find that certain foods don't tolerate with you, yet if you go and see a gastroenterologist, they don't necessarily
They say
identify
there's nothing wrong.
any
Yeah.
any particular dysfunction with your gut, or you don't necessarily have an allergy to a food. I think another great example is something like, and I see this a lot clinically, is things like dysmenorrhea. So females who present often with a lot of pain during their menstrual cycle, and like I think of a patient at the moment who I'm seeing who gets really bad migraines only during menstruation, but no other time of the month. Yet this person, and I've had plenty of patients like this who have had done all the right things and seen um, the right medical staff to rule out things like endometriosis or polycystic ovarian syndrome, or any other type of evident imbalance within the hormonal system, where these are people who may have a potential response to doing certain musculoskeletal type treatment. And this is through understanding that when we treat, say, the abdominal region of the body, when we talk about the digestive or reproductive system, there is a very intimate relationship between that insertional fascia that I mentioned before to the abdominal wall. And so there may be an ability to change some of the stiffness properties within that insertional fascia that can alter the motility of that organ, that may help with reducing some of the pain that they experience with related to whatever aggravating factor that it is.
Okay, so that straight away you start thinking, okay, well, what does that actually look like? Because that seems, well beyond what most people would consider possible. So, what kind of, you know, techniques and things are you actually looking at doing to be able to actually address this? Because
Mm.
it seems like the first thought that would go through most people's heads is like, you're probably not going to be able to make changes, or even be able to influence that from a manual therapy point of view.
Mm. So the same principles apply to what I've talked about before with myofascial pain, where you see the same changes within this visceral fascia that you do within the the muscular fascia that causes myofascial pain. So this goes back to understanding that within the fascia, you have different layers. Within those layers, you have the ability, or ideally, those different layers and should be able to glide independent of each other, which is important for normal function of the fascia, whether we're talking about the deep muscular fascia or the visceral fascia. And also provides really important information in terms of sensory feedback to your nervous system to maintain normal function. And something that has been very well explored and established is how shear forces can create mechanical forces at that interface to restore that gliding of the fascia itself. And so the theory, and this is, I think, important to highlight at this point, because when we talk about internal dysfunctions, a lot of this at the moment is theoretical and looking at some of the anatomical relationships that have been explored, is that you can cause a similar change within the insertional fascia that connects between the muscular and the actual organ itself. And I think this is
Is
important.
this some of the research that they're starting to look at? You were mentioning before a paper they're doing. How are they actually designing the papers? What are they trying to look for?
Well, at the moment, they're still really putting in the time to explore a lot of the anatomical relationships between the internal system to the muscular system. I think the one important thing to establish is the actual relationship themselves, because when we actually, and there's some interesting stuff looking at this. Like another example I would give is looking at, say, the pleura of the lungs and the relationship it has to the intercostal muscles. So when you actually look at that relationship, there is no separation between the parietal
Hmm.
pleura and the intercostal muscles. And that actually makes a lot of sense too, because when you think about the importance of being able to regulate our thoracic cavity through certain muscle movements, helps you to really appreciate how you can create big changes within the lung size and be able to optimize respiration. So a lot of the work at the moment is still looking at that anatomical relationship. From what I understand, they're looking at going through the same process of what they've done with the musculoskeletal system of, once they've understand the anatomical relationship, look at the pathophysiological changes of the viscera within these sort of dysfunctional states, and then eventually look at doing some applied research. So it's certainly, I think it's very fair to say that the burden is on them to really help to actually put the research forward to actually demonstrate that this relationship and this particular phenomenon occurs. But I think at the
I,
moment, go on, John.
no, I always think about this in the sense that I find it very interesting, and we've spoken about this before, but that anatomical research, for whatever reason, seems to still be lacking in this area in particular, which I don't really understand because it's pretty plainly obvious that these structures exist. And we've been, doing dissection for hundreds and hundreds of
Mm,
years.
mm.
It doesn't make sense that a lot of this hasn't necessarily been described at the level that it should be,
Yeah,
like other areas of the body.
well, it's interesting. Carla has talked about this before, and I mean, her work is really starting to create a lot of changes within the anatomical research. Like she spends a lot of her summer now going around to other universities around the world, demonstrating her dissection techniques that preserve the fascia. And she talks about that. And remember, she's the professor of anatomy at Padua University, which is where anatomy began. And if you look at some of the earlier texts that came out of some of the universities in Italy, they do talk about the deep fascia or the superficial fascia or the visceral fascia. But then there is a period where you can see that there's less attention put towards the fascia and more to what you see now in most anatomical textbooks, where they just talk about the organ or the muscle in isolation. And it seems that from my observations, the reason for this is because when you take away the fascia, it creates a lot more simplicity and linearity with how we look at the human body. Because fascia does create a lot more complexity with looking at the intimate relationships between different muscles, but then also within different organs within the body, because there seems to be almost myofascial planes within different organs in the internal system, and then of course the relationship between the internal fascia and the muscular fascia. So I feel like at the moment there is a bit of a revolution going on within the anatomical space of really trying to reconceptualize how we look at anatomy and actually start to dissect the body with preserving the fascia to be able to appreciate continuity within the body. And like I think of some of the conversations, and I know we've spoken before, John, after some guests we've had on the body who look at, say, the musculoskeletal injuries, and they have these models that don't include fascia. So we have to understand that at the moment, it is something that is consistently missed. Actually, I think of another example. When we were lucky to have John Sherbel on our podcast more recently, and a question I asked him was the relationship between trigger points and densifications. And he seemed to see those things as very separate. And I guess for me, and obviously I have a bit of a bias, as I think of surely there must be a relationship between fascia and trigger points, because the current model doesn't include it. It's very much like that muscle, neurological, vascular relationship. And it was actually a conversation I had with Antonio when I saw him last week, of going like, do you see if there is a relationship or not? And it was interesting because he actually showed us some of the research that's been done on this, that when you look at a densification under ultrasound, it shows a hypoechoic region. So a region under ultrasound where you see an increase in fluid. You see the exact same relationship and ultrasound image when you look at a trigger point. And so it does seem that when you look at trigger points, there does appear to be changes within the fascia that also have an impact on a trigger point forming. And that, to me, makes sense, because trigger points typically happen because of changes in the local tissue, causes this negative feedback loop through the nervous system that causes an increase in tone within that particular fascicle or portion of the muscle. And I think in very chronic types of trigger points, you also see changes within the deep fascia that in the form of a densification that then further reinforce that negative feedback loop through the neural system. And that actually makes sense, I think, from a clinical perspective, where there are certain types of trigger points, if they're very acute, you can, say, needle them or do different types of manual therapy technique and they go away. But there are ones that continually come back. And I think often those ones are the ones where you have changes within the deep fascia that may not get restored from certain types of manual therapy techniques that we often use to treat a trigger point. And so that's a bit of I'm going off on a bit of a tangent there, but I think it's one of the big limitations at the moment is really thinking about fascial anatomy. And I think more importantly, we probably need to stop even using that term, that we should be thinking of myofascial anatomy or visceral fascial anatomy in the examples I'm giving at the moment, because we shouldn't see these as separate tissue systems.
How do you think that and where do you think this concept ends up when it comes to, anatomy? Do you think that it creates a very different model, or is it a model that's very similar, but the conversation has continued to include some of these other things? And fundamentally, will it change the way we sort of approach musculoskeletal, injuries or pain?
Well, look, I think so. I mean, I think from the simple standpoint is, as we get more of an understanding of changes within the fascia with things like myofascial pain, it opens up avenues for us to be able to visualize and quantify changes within the fascia that may be associated with someone's presentation. Because at the moment, I think one of the big issues we have with things like myofascial pain is it's typically a diagnosis of exclusion.
Yeah,
And part of that
so
is
it fits into that non-specific kind of grading of presentations, which I know as a clinician, we always struggle with, like people come and they have non-specific low back pain, and it's not really a helpful kind of, starting point when there really isn't something, as you said, either to visualize or be able to pinpoint from a structural standpoint.
Totally. And like, I think, and to be fair, the burden again is on researchers to put the work together to be able to quantify, because I think that's one of the big limitations we currently have is, again, most of the time we should be able to, or at least want to be able to visualize some type of structural pathology, but there isn't any necessarily change of the fascia at a macro level, but we do see changes at a micro level when you look at the mechanics. Or I know there's been some interesting research done looking at different types of MRI techniques to see changes within the extracellular matrix of the loose connective tissue, which is where a densification forms. And I think that's a really important step to then have more recognition and acceptance within the medical fields or within healthcare professions to be able to see that change. And there has been some research that's been done already demonstrating this, but I think this needs to be something that's done more repeatedly, and then obviously eventually be able to have be able to do this at a clinical level as well, and not just purely within a research setting. And I think that's, over time too, you can see that once we get a much more of an appreciation and ability to be able to quantify myofascial pain and not just simply see it as a process of exclusion, that has a lot more acceptance and therefore opens up avenues for treating myofascial pain. Because I think at the moment, that's why we see currently the narrative around myofascial pain or non-specific pain is to do more like general education and pain management and general exercise, which, not to say that those may not have a role, but they obviously are very non-specific in nature as well. And from my experience and from some of the research that the Steco group have done on looking at things like non-specific low back pain, you can actually see much more significant and superior results from doing much more localized treatment to identify the source of dysfunction within the fascial system to see a better resolution of someone's non-specific pain.
Do you think that that is the shift that we will see, that we get to the point where we can heavily identify, even if it is within the myofascial system, the structures that are contributing to the development of that pain itself?
Oh, absolutely. I think like currently the two methods that seem to be more consistently used is looking at dynamic ultrasound, because this concept of looking at gliding within the interface of the deep fascia is something that you can see on dynamic ultrasound. So the most well done paper on this is a paper by Alan Langevin in 2012 on looking at reductions in the shear strain of the thoracolumbar fascia in chronic low back pain. And so her work demonstrated that there was a reduction in the gliding of the different layers of the thoracolumbar fascia for individuals who have long-term low back pain compared to those who don't. There's also been some research of looking at things like there's a particular type of MRI called a T1 row, which can quantify the amount of bound versus unbound water. So in a densification, we'll take a step back. Within the loose connective tissue between the deep fascia, you'll typically have hyaluronan that binds to water to create a lubricant-like substance to allow that gliding. In a densification, you get hyaluronan that binds and aggregates to itself, and then you end up with this bundle of hyaluronan and unbound water. And so T1 row imaging can quantify the amount of unbound water. And there's a particular study done by Menon, his surname is, of looking at people with lateral epicondylalgia, so lateral elbow pain, looking at the amount of unbound water, and in response to certain types of manual therapy, seeing reductions in the amount of unbound water. And this follows the premise of understanding that shear forces can cause that aggregated hyaluronan to break up and then bind to water again to restore a more lubricant-like substance within the loose connective tissue. So what I see as being really important moving forward is these type of imaging techniques become readily available. And like I think we'll probably see that pretty soon with things like ultrasound and dynamic ultrasound, where ultrasound imaging is a lot easier to access clinically. And then I think eventually even looking at things like certain types of MRI techniques to be able to see changes within the loose connective tissue that may be associated with chronic low back pain, to give us an indication of, and this is where I think they need to put in the work to look at, what are particular thresholds to determine, say, pathological changes within loose connective tissue, to give a diagnosis of things like myofascial pain.
Is this sort of some of the stuff that Paul Hodge's group is now doing with the stechos?
Well, the only study that Paul has done with Carla is looking at where these changes within the fascia occur. And so they look specifically at seeing changes within the perimysium that affects the function of muscle spindles. And so that helps to understand some of the changes in EMG activity that occur in chronic, say, low back pain, because you see alterations in mechanoreceptors that in the periphery that provide feedback to the central nervous system that influence neuromuscular patterns. And I see that as really important because it really highlights that when we think about sensory motor control, peripheral changes will regulate some of the EMG patterns that we see, and in particular, some of the abnormal patterns that you see in chronic pain presentations. And that then, well, at least alludes to the importance of then peripheral modalities to be able to positively change neuromuscular patterns and ideally reduce pain. So what Paul's working on at the moment, I'm not exactly sure, but he's certainly been someone who has at least understood and realized that fascia has been underappreciated in our understanding of musculoskeletal pain and dysfunction.
Where do you see, obviously, the physical therapy world has heavily shifted towards exercise, and we've spoken about that a lot.
Mm.
Where do you see those modalities fitting in with something like fascial manipulation? Because I know that in some of the discussions that you've had with the sectors when you've been over there, they're very heavily weighted towards manual therapy. And we've discussed the benefits of that, especially for younger clinicians who have abandoned a lot of manual therapy. But where do you see that there's also benefit to add from, the training that you've had in physical exercise and implementing this, particularly for you? The musculoskeletal system is something that you have been able to heavily influence through your flexibility training, yoga and stretching implementation that you use. Do you see that these things also will be able to contribute to some of this conversation when it comes to modalities and interventions that will affect the myofascial system positively?
Look, absolutely. And look, to be fair, the teachers at the Fascial Manipulation Institute talk a lot about exercise. I think generally speaking, they see exercise as a fundamental element post manual therapy to restore the normal tissue mechanics. And actually, recently Carla presented a small study that she's done with a group of fascial manipulation clinicians in Italy for treating low back pain. And they did a series of outcome measures of looking at both subjective measures and questionnaires of looking at improvements in pain and function. But they also did some objective measures too. And it was interesting, actually. One of the objective measures that they looked at in the low back pain group was strength endurance measures of things like a Sorensen's test, or like an isometric trunk flexion test for abdominal strength endurance and things like that. And it was interesting, actually, because typically what they found was in the chronic low back pain group, a lot of them had just to take a step back, in this study, all they did was manual therapy. They applied the fascial manipulation technique, and they did up to 5 sessions. And overall, there was, I think, 100 participants in the study. They saw significant improvements in their pain within those 5 sessions, which is great. But it was interesting to look at some of the objective measures. And some of the objective measures, when you look at, say, pre-treatment and post-treatment, didn't necessarily change. And one of these was actually looking at, say, a Sorensen's test for looking at strength endurance of the lumbar rectus spinae. And at first, some they were a little bit surprised by that, but I actually mentioned to Carla that actually doesn't surprise me at all, because when you think about someone that's been in long-term pain, one, they often avoid doing certain activities or doing activity in general. So they go through a detraining effect. I think the other big one too is, and this is a lot of the research that Paul Hodges has done, is in the presence of pain and detraining, you start to see changes in the muscle fiber typology. So when you think about the erector spinae, particularly the deep erector spinae like the multifidus, they're highly innervated in slow twitch fibers, but you actually start to see them transition to much more your fast twitch, and particularly 2X type fibers that are very much a hybrid, which actually makes a lot of sense then to see reductions in the strength endurance. And it's interesting to note because in my experience, you often see improvements in someone's peak force in restoring their normal tissue mechanics, because it inhibits or reduces that inhibitory feedback to the central nervous system. But you don't necessarily expect to see an improvement in strength endurance. So this to me really highlights that you do need to think about the importance of exercise with someone's presentation, particularly with long-term problems, because you're very likely going to see some dysfunctional changes within their tissue capacity. And I mean, you could obviously see reductions in their peak force, particularly in more active population groups, because of the fact that they haven't been able to train to the same intensity. When I think about myofascial pain and using exercise to treat myofascial pain, the first limitation I see is exercise or mechanical force from exercise cannot be localized to a particular tissue region. And it seems to me that one of the things that's evident within the human body is we are very good at compensating for local or regional changes or dysfunction. And this is something that I think you need to be cognizant of, because if someone does have myofascial pain due to a densification within their fascia, if you apply mechanical force, you may not be able to localize it to that point of densification. That in your body actually creates neuromuscular patterns to try and distribute the forces around that densification, because it knows that it is dysfunctional. And sometimes this is evident because if you try to get someone to do a particular exercise, it actually reproduces a lot of their pain, and therefore you're not able to. Or you may not necessarily see the response or improvement in their symptoms as quickly as possible. So I very much use the clinical framework of, if I suspect that there is changes within their fascia that's contributing to their pain, I'll use manual therapy modalities to try and restore the mechanics of the tissue at a local level. But then I do think it's very important then to consider the framework of, well, what are contributing factors to this person's presentation? And that may be related to poor tissue capacity in terms of their range of movement, strength, power, and so on, to make sure that you actually restore that through exercise modalities. And in my experience, when you follow that order, you see a much bigger improvement or response from the exercise modalities, because one, they're able to do things much more effectively because they obviously have less pain, but two, you restore better neuromuscular patterns because you're not having to create compensations due to the localized dysfunction of the tissue from a densification.
I don't know if I've asked you this, but
Mm.
as we talk about this, I'm thinking about like the evolutionary pressure that causes the development of things like densifications. And do you think
Yeah.
it's very much a reflection of just our, inactivity generally and sedentary lifestyle now that we develop these? Because it doesn't
So,
make sense that you would need to seek out manual therapy as a cave person,
well,
like that doesn't make
it's actually
sense.
funny you say this, because I've had this conversation a few times. It makes you realize and appreciate that, for particularly you see it in animals still a lot. What are they doing all the time? They're scratching themselves, they're rubbing themselves. And part of this is when you think about itching or scratching, or the feeling of itching, that often has to do with a tension within your fascia. So I think I wonder if a lot
What
of
could be poison ivy, Jack?
well, but outside of some exogenous substance causing some tissue irritation. And I actually do wonder the very same thing, John, of have we maybe lost some of the innate abilities that maintain good tissue mechanics because of one, sedentary lifestyle, because we move less, and two, perhaps reductions in things like interoception, i.e. body awareness, where, like you might actually often rub certain parts of your body because you actually feel a point of tension and you essentially eliminate it before it becomes more problematic. Because I agree with you. It doesn't really make sense that as cavemen, we're all like getting into each other and rubbing each other. Or maybe we were, I don't know. But you see it a lot still within the animal kingdom where you see dogs or cats who are continually grooming themselves and rubbing parts of their body. Or like, a good example I think is if you look at like bears who come out of hibernation when they go up into the tree and they're there for half an hour, actually just really rubbing their tissue against a tree
Yeah,
to
that's a good observation.
restore
The
the normal gliding of their tissue. And I think that's something that we as humans have lost
lost,
because of,
yeah,
I guess,
those behaviors. Yeah.
yeah, we don't. That's either, I think, partly related to the fact that we are sedentary, partly related because we don't actually have much downtime these days, where we're actually just sitting going, oh yeah, I've got a little bit of attention in there and I actually just work on it for a little bit. Like we're often distracted these days where you're doing something or you're watching TV or you're on your phone. And so you don't actually spend time to actually scan your own body.
Hmm.
And to be fair, some people are much better than others. And that's where I do think, things like foam rolling or other self-treatment techniques are really useful because apart from just using your hands, you can actually use other types of devices to make sure that you maintain good tissue health and quality before it becomes more problematic and you actually need to seek someone else's services to address it.
Hmm. Um, Before we wrap up, is there anything else that you sort of have come across so far on this trip that you want to share with us that you found interesting, or the conversation you had that's piqued your interest in something to do with, musculoskeletal health?
No, I think then most of the things that I've taken away from this trip. The other thing that I've actually really appreciated from this whole experience, and I think this is actually an important one because we
Your
often
sunscreen?
underappreciate. So, yeah, well, that's evident, isn't it? Um, is the skills that we can develop with our hands, because I think that's something that we have often just neglected or underappreciated these days. And it's so interesting to see the evolution of skills within the group that I'm doing this course with, of how it improves and how we start to see changes in our abilities to have good inter-rater reliability. So something that, just to give some context, something that we did a couple of times, and we do this each time we do the course, is we do inter-rater reliability tests where there'll be two clinicians and one therapist, and we have to palpate different points and rate the quality of the tissue, and obviously blinded from each other to see how much correlation there is. And to begin with, when we first did it at the beginning, it was pretty low. But you can start to see that it's actually building now, and that the correlation between different clinicians is getting higher and higher and higher. And I really emphasize that because I think it's something that we don't really talk about or appreciate, and that is what we can feel with our hands and how that is actually just a skill that just takes time to develop. And I don't expect it, you can't expect it to necessarily get better after, one day of learning about a particular technique. And I think that's something that we need to, one, spend more time on actually working on, and two, really appreciate, because we can get a lot of information using our hands to help guide what we do clinically.
Hmm. I think yeah, that's a good point to end on. Jack, I won't hold you up anymore. You can go and enjoy getting more sunburn.
Nah, I
Uh,
think I'll stay out of the sun for a bit, John.
Thank you so much for taking the time out of your Sunday to do this, and I will be in touch, I'm sure. But to all of our listeners, if you have any questions or anything related to the discussion today, make sure that you do reach out through any of our social media channels or via our website. Thank you for joining us.
Thank you.